Hello and welcome to Insight Ophthalmology. This is Dr. Amrit welcoming you to another important lecture. Today we are studying the role of anti-VEGF agents in diabetic retinopathy. So as we all know that hypoxia in the retina will induce the production of vascular endothelial growth factor, and this VEGF is produced by the retinal endothelial cells, the Muller cells, the retinal pigment epithelium, and the astrocytes as well. As we all know that the vascular endothelial growth factor will lead to the production of numerous new vessels in the retina called the new vessels or neovascularization, and whenever there is neovascularization, the stage of retinopathy is called the PDR or proliferative diabetic retinopathy. Now why is this so important is that the proliferative form of diabetic retinopathy is associated with severe vision loss, and severe vision loss is defined as visual acuity less than 5/200. The VEGF family is a huge family in which there are 7 types of members, but what is most important to us in ophthalmology is the VEGF type A, because this promotes the increased vascular permeability by the breakdown of the blood-retinal barrier and brings about angiogenesis and neovascularization in the retina. And in this VEGF A, the most important isoform is the VEGF A 165 splice variant. So this table is a comprehensive table which shows you a lot of VEGF family members. The most important here is the VEGF A, and in the VEGF A, it is the A165 splice protein which is important with respect to the eye. The receptors that you should know is the VEGF receptor 1 and VEGF receptor 2, and in this the VEGF receptor 2 is more important. Apart from that, what you should know is the PIGF, that is platelet induced growth factor, which is associated with inflammation in the eye and causes vasculogenesis and neovascularization. Now, the VEGF is basically a dimeric protein. Okay, so it is a dimeric protein which is going to bind to the VEGF receptors. As I told you specifically, it is a VEGF receptor 1 and VEGF receptor 2. And these receptors are the tyrosine kinase receptors. So what happens is that these receptors actually have an outer domain which is called the ectodomain, and they have an endodomain which is present inside the cell. Okay, now the dimeric VEGF protein is going to come and bind to these receptors, and it is going to bind to this part of the receptor which is present outside, that is the ectodomain, and then it will initiate a tyrosine kinase activity leading to finally the angiogenesis. Now why this is so important is that because in the recent advances, now a lot of tyrosine kinase activity inhibitor drugs have actually come up now, apart from the anti-VEGFs. Now, before I go into the anti-VEGFs, it's very important to know the basic structure of an antibody. Now, the antibody basically consists of the binding domains which are called the FAB fragments, and then we have below that we have the FC fragment. So, the FAB portion is responsible for binding with the target, and all the effector activities or the whatever effect the antibody will bring about is carried out by this FC portion. So, remember there's an FAB portion and there's an FC portion of the antibody. Now the first anti-VEGF which was actually developed or discovered was the pigaptinib or the Macugen. Now Macugen is nothing but it is an aptamer. Aptamer is nothing but it is a highly selective oligonucleotide sequence. So it's a continuation of oligonucleotide, and so this is it consists of 28 nucleotides. So oligo means short and nucleotide you already know. So there are 28 nucleotides in the RNA and it is called an aptamer. Now pigaptinib is important because it binds specifically to the VEGF A165 isomer, which is a very important isomer of the VEGF A family. Now, important thing is that pigaptinib is actually approved by the FDA in December 2004. However, it was approved for neovascular AMD. But we are studying about it here because it was the first anti-VEGF that was discovered. Now next we have the BEVACIZUMAB, also called the AVASTIN. Now AVASTIN is actually, if you would remember the structure of the antibody, the AVASTIN is actually a monoclonal antibody. Okay, it is a full length recombinant humanized anti-VEGF monoclonal antibody. So this it's an anti-VEGF, so it is definitely going to bind to the VEGF, and it is going to prevent that VEGF from binding to the VEGF receptors. Now, since it's a antibody which actually consists of both the FAB fragment and the FC fragments of the monoclonal antibody, so it is quite heavy. It is 148 kilodaltons, and the Food and Drug Administration, that is the FDA, it actually approved it not for the ophthalmic use but actually for the metastatic colorectal cancers. So all those people who are actually using bevacizumab, it is an off-label use. It is not approved by FDA for the ophthalmic use. How it was approved for the treatment of the colorectal cancer. So coming to the dosage is 1.25 to 2.5 milligrams per 0.05 ml. Now, since it's a bigger molecule, the half-life of ranibizumab, when we talk about the serum half-life, is about 20 days. Okay, quite double to that of the ranibizumab. And why is that? I will tell you in a short while. Now, the bevacizumab is the structure is very similar to a human antibody, okay, and the reason is because it is actually nothing but a monoclonal antibody which is actually acting against the VEGF. So what happens, this antibody is going to bind to whatever VEGF is available in the eye, and since it forms a complex with the VEGF available in the eye, this VEGF will not be available to bind to the VEGF receptor and then to bring about the angiogenesis inside the eyeball. However, there are a lot of side effects of this bevacizumab therapy. Specifically, it can cause uncontrollable hypertension, it can cause proteinuria, it can cause thromboembolism and gastrointestinal bleeding and perforation. Coming to the ranibizumab. Now, ranibizumab is also known as LUCENTIS by the trade name, and the dosage is 0.3 to 0.5 milligrams by 0.05 ml. That means the dosage that we give is about 0.05 ml. Why ranibizumab is important? Because it is actually approved by the FDA in 2017 for diabetic retinopathy. Now, this one is, in comparison to the bevacizumab, it is only a fragment. And if you ask what fragment is present in the ranibizumab, it is only the FAB moiety of the monoclonal human immunoglobulin IgG1. Now, the bacteria that we are using is E. coli. So, using that E. coli, we are trying to produce that recombinant antibody fragments from to produce the ranibizumab. Now, ranibizumab is much better compared to bevacizumab, and that is why it is approved by the FDA. Ranibizumab binds with increasing affinity to all the isoforms of VEGF. Moreover, what happens is that it diffuses also better in the retina and the choroid. The half-life is much shorter compared to the other anti-VEGF molecules due to the lack of the antibody FC domain. So if you talk about the half-life, it is about 9 days in case of ranibizumab. And if you remember, when I talked about the bevacizumab, it was 20 days. Now here I'm trying to tell you the half-lives, which are the serum half-lives. Okay. Now there are a lot of controversies about these half-life. Different half-lives are given in different journal articles. So if you see here for the ranibizumab and for bevacizumab, the serum half-life roughly for ranibizumab is 9, and for bevacizumab it is about 20 days. However, when you come to the intravitreal, how much for how long they stay in the intravitreal, if someone asks you, it is roughly about 4 to 5 days or 4 to 5 days in both. So both of them have the intravitreal half-life is roughly 4 to 5 days. So there's a lot of controversy around this the half-lives of the drugs. So as I told you that the ranibizumab is actually just a fragment of the bigger antibody molecule. So this is the antibody which has an FC portion and an FAB portion. The ranibizumab only has this FAB portion, right? So this is how it binds to the VEGF-A with a greater affinity compared to the bevacizumab, and when it binds with this, it will not allow this the VEGF-A to bind with this receptors. It is available as LUCENTIS, and then there's an Indian brand which is called Centrix, which is also supplying the ranibizumab. Now, since the dosage is the two types, 0.3 milligrams and 0.5, the FDA has approved 0.3 milligrams. However, okay, now it's available as a 10 milligram per ml vial, which actually from one vial you can give about 20 doses of the injection. The next drug, which is another important drug, is the aflibercept. Now, aflibercept is also called the Eylea or the Zaltra. It is actually a fusion protein. And why is it a recombinant fusion protein? Is because it is combining some parts of the VEGF receptor 1, VEGF receptor 2, and those parts of VEGF receptor 1 and 2 are fused with the Fc domain of the human IgG. Okay, now what it does is it is going to trap the endogenous VEGF molecules and it is going to bind with them a lot better affinity, with a greater affinity than the other type of anti-VEGF. Now, one more important point about the aflibercept is that it is going to block almost all the types of VEGF, whether it is VEGF A, B, and along with that it binds with the placental growth factor PIGF. Okay, so I'm so sorry, it is placental growth factor PIGF 1 and 2. Now, what is the dose? The dose is 2 milligrams by 0.05 ml. So that means the volume that you are giving is 0.05 ml in the injection and the dosage is 2 milligrams. Now, FDA actually approved it initially for the neovascular age-related macular degeneration in 2011 and later it was approved for diabetic retinopathy as well in 2015. So if you see this is very similar to the antibody that we have seen. So the Fc portion is same. However, what is this over here? So if this is the VEGF receptor 1 and this is the molecular structure of the VEGF receptor 2, you can see the second domain of the VEGF receptor 1 and third domain of the VEGF receptor 2 has been taken and has been put up on top of the Fc part of the human IgG1. Okay, so that is how this fusion protein or aflibercept develops. Now, what is meant by VEGF trap? VEGF trap is nothing but within this aflibercept molecule, one dimeric VEGF, we know that the VEGF is actually dimeric. So one part of the VEGF is going to combine here and one part is going to get combined here. So between these two arms of the aflibercept, the VEGF dimer is going to bind with a unique binding action, forming a very inert 1:1 complex, and this complex is called a VEGF trap. Okay, now here I would like to tell you something about the dosage of aflibercept as well. Now, when you talk about ranibizumab and bevacizumab, usually we give monthly injections and those are given till we achieve some stability in terms of OCT thickness and best corrected visual acuity. However, when you talk about the VEGF trap, that means when you talk about the aflibercept, the dosage is 2 milligrams, okay, and the volume is 0.05 ml and you are administering it intravitreally every 4 weeks, that is monthly, for the first 5 injections or the first 3 injections in some cases. However, after the initial loading dose, you have some maintenance dose as well for the aflibercept, and that maintenance dose, the dosage is same. However, the duration is enlarged. So every 2 months, that means 8 weeks, you have to give 1 injection when it comes to aflibercept. Now, when I talked about the VEGF trap, I told you that in VEGF trap, what happens is the two arms of the antibody is going to bind with the VEGF, okay, in between. However, ranibizumab also binds with a single VEGF molecule because only on one, but however, it is only binding it to the VEGF particle on one side. Then when we talk about bevacizumab, on the other hand, it can bind to multiple VEGF molecules because it can bind someone here, one here, one here, like that. Okay. Now, which drug should we use? We know that these are the drugs. Now, which one should you use? How you choose a drug depends on the aim of treatment, whether we want a better vision or better drying, which one is a longer acting agent. The drug should be having least side effects, and obviously the cost of drug as well. Okay. Now, there's a rule for treatment that is called a 10% CST and 5-letter rule. Now, 10% central subfield thickness. So, in my video on OCT, I already told you what is meant by the central subfield thickness. So, what happens is when you start treatment, you start with the baseline OCT and baseline visual acuity, okay, or the best corrected visual acuity. During each follow-up, the same are repeated. Now, if the person's central subfield thickness is increased by 10% of his initial central subfield thickness in the initial visit, or if the visual acuity is reduced by more than 5 letters, that is equal to 1 Snellen's line, then the patient is said to be worsening. However, if the CST increases by more than 10%, Okay, if the CST decreases by more than 10% and the visual acuity is actually increasing by 5 letters, then that is said to be an improvement, okay, on the follow-up. So this is what is meant by the CST and 5% rule. So as long as the patient is either improving or worsening, you have to continue giving the treatment to the patient. So if the patient is worsening, you inject. If the patient is improving, you have to inject. And till when are you going to inject? You are going to inject till he becomes stable. Obviously, the aim is to get a better visual acuity. We have to get about 6.9 or better. However, treatment is often stopped when the patient reaches stability. Stability means that the patient's central subfield thickness and best corrected visual acuity are not changing in 2 consecutive follow-ups. Now coming to the treatment regimens of the anti-VEGF. Now there are 3 types of regimens basically for anti-VEGFs. These are the fixed monthly regimen, the pro-renata and the treat and extend. The fixed monthly regimen is nothing but in which we inject 1 injection every month. The problem with the fixed monthly injection is that it's not quite practical. There's a risk of infection because every month you are injecting. Obviously, economical burden will be more and it's time consuming. The pro-renata is also called as and when required regimen. In this, after the initial 3 months of initial loading monthly injections, what you do is you have to follow up the patient every month. So patient comes back every month. However, the injection is only given when it is needed. So this can be understood by this diagram. So you can see this represents the number of months. So the patient is visiting every month. However, the injection is being given only when it is needed, okay, based on the OCT and best corrected visual acuity. When the patient is stable, then no injection is being given. So the visits are monthly. However, the injections are not monthly. So this is called the pro-renata. Then we have a treat and extend. In treat and extends, again, the monthly injections initially are given till the stability is achieved. And then what you do is, instead of calling the patient every month, you will follow up the patient, and when there is stability based on the CST and best corrected visual acuity, your follow-up also will be gradually extending. The follow-up can be extended by 1 to 2 weeks, and you keep on extending it to a maximum of about 12 weeks, and 12 weeks is nothing but 3 months follow-up. If, however, the patient worsens in between, then you start reducing the follow-up period, and the minimum that you distance between or the time period between 2 follow-ups can be about 4 weeks. Now, under treat and extend, the important thing that you should know is that the patient is being given injection whenever he is coming. So as you can see here in treat and extend, patient is coming. Okay, during the initial period, he's being given injection every month. After the stability is attained, then you start increasing the period between the follow-up, that is by about 1 to 2 weeks, right? However, and then suppose the patient is again stable, then again you increase by 1 to 2 weeks, and then again you increase the follow-up period. But what is important is whenever the patient is coming, you are injecting you are definitely going to inject the patient with the anti-VEGF. So this is called treat and extend. So the main difference between treat and extend and PRN is that the treat and extend is actually a proactive measure in which you inject the patient on every visit. However, the follow-up is being extended. In PRN, it is a reactive regimen. That means you are going to inject the patient only during the follow-up. You are going to inject the patient only when you feel that there is a need to inject him. Coming to the complications of anti-VEGF. Now, there are a lot of ocular side effects with anti-VEGFs. There can be transient increase in the intraocular pressure. Patient can report floaters. There can be damage to the lens, and along with that, there can be chances of endophthalmitis. Okay, it's not very common, 1 per 1,000 injections. Patients can develop uveitis. It's more common with aflibercept and BEVACIZUMAB. They can develop tractional retinal detachment, specifically in patients who have pre-existing membranes. Now, why does that happen? Basically, a membrane usually has a fibrous component, and it also has the vascular component. Now, you're taking care of the vascular component by giving the patient VEGF, right? However, what happens when the VEGF component is gone? You are left with only the connective tissue growth factor or the fibrotic component, and then that fibrotic component is going to undergo contraction, and as it contracts, it pulls the retina along with it, causing traction on the underlying retina. Coming to the systemic side effects, they can be increase in the bowel perforation rates, arterial thromboembolism, myocardial infarction, stroke, and definitely hypertension. Now, there are certain times when we are not supposed to inject the anti-VEGFs in the patient's eye. So what are those times? Specifically, fibrovascular proliferation, which is threatening the macula. The reason is, as I told you, that anti-VEGFs can cause tractional retinal detachment as well. So therefore, specifically when you have fibrovascular membranes near the retina, near the macular area, you're not supposed to inject anti-VEGFs. Then patients who have active ocular and periocular inflammation, known hypersensitivity to drugs, uncontrolled hypertension, again, diabetes, cardiovascular diseases, patients who are on anticoagulants, again, they should not be given. Pregnancy and lactation are also contraindication for the anti-VEGFs. Now in my next video, we will discuss about the clinical trials of anti-VEGF and in a way that how do you apply this to your practice. Thank you and have a